Research Seminar Series. Dr. Joe Keating is our lecturer today. He is an epidemiologist who focuses on vector-borne diseases, including malaria. He's Associate Dean of Undergraduate Education in the School of Public Health and Tropical Medicine, a professor in the Department of Tropical Medicine, and Vice Chair of Tulane's Institutional Review Board. Dr. Keating was a Peace Corps volunteer in the Gambia, West Africa, before beginning his teaching career. Here at Tulane, he has received the Outstanding Undergraduate Teacher of the Year Award 3 times. His fun fact is, before beginning his career in epidemiology, he spent several years as an industrial mason and log cabin builder in Kentucky. Dr. Keating will talk to us today about the use of human subjects in research. Please join me in welcoming him.
Thanks, Lisa. Y'all want to talk about log cabins or public health stuff? Yeah. Okay, we'll focus on this. So the actual theme of today, this is not entirely correct. I mean, obviously we're going to talk about ethical issues, but the theme is actually ethical issues in international settings. All of my work is overseas for the most part, and certainly the issues and challenges that we face overseas are not the same ones that you may face here in the United States or a Western European country, et cetera. So let me also preface this discussion basically with saying 2 things. Number one, I don't mean to stand up here and suggest I have all the answers. I have probably more questions than I have answers. And number 2, if y'all have something to contribute, please feel free. I'd certainly welcome your involvement. In fact, I might even ask you a question or 2 for those that have had me in class. So I know a couple names in here, so watch out. So anyway, just to get started, and some of this might be a bit redundant at first, but just bear with me. I wanted to make sure we at least sort of covered our bases, sort of what we're going to go through today. And again, in the context of international research, is sort of how do we handle these different components that go into what we have here in the United States in terms of federal regulations and compliance issues around the rules and regulations of doing research. How do we handle these situations when we're doing work overseas, right? So respect of human subjects, the informed consent process, very tricky business there for sure. Compensation, is that allowed? Is it not allowed? How much is too much? What's coercion? Things like this. Risks versus benefits, different cultural contexts define that in different ways, of course. How do we select our study subjects? A lot of times these are not clinical trials that we're doing. Most of the work we do is population-based epidemiology, so it's the opposite of clinical trials. It's usually our phase 3 type studies that you might be familiar with, and effectiveness or just evaluation of different interventions going on. And then sort of how we define and get around the scientific and social value of the study when there are cultural nuances that keep us from being on the same page in different countries, right? So this is sort of what we're going to try to get through today as much as possible. But again, it's a function of questions and answers, et cetera. So real quickly, what prompted all these discussions? I think everybody's well aware. We've got a few classic cases that certainly prompted these discussions. The Nazi medical war crimes, of course, that was number 1, and the syphilis studies here at Tuskegee, certainly number 2. That led to a whole host of discussions globally, not just in the United States, that then led to basically what we have now as the common rule, right? All of that sort of morphed into the common rule over the last 60, 70 years. But it started with this. It started with no compliance, no regulatory bodies. They're looking at what's risky to a subject, what's beneficial to a subject, et cetera. By and large, most countries do have their own regulatory bodies. They do have their own compliance rules, et cetera. And then the question becomes, as a foreigner operating in a different country, whose regulatory body do you actually follow? What compliance matters do you have to pay attention to in that country versus your own country? And oftentimes it gets even confounded worse with you've got to somehow appease both, right? You've got to somehow make that work. You've got to match up and make both your study fit their understanding of what's compliant and our understanding of what's compliant, which is easier said than done for those of you that have been involved in multi-center studies Sometimes we're looking at 6 or 7 IRBs that have to get on the same page with what's being done. So certainly a different, tricky business here. So the 3 principles, again, you've probably seen this before, but respect for persons, obviously that's what's guiding us, even in the international setting, looking after the welfare of your study subject, and then justice, right? These are the guiding principles across the board, irrespective of what country you're in. This is what keeps us going and what we're supposed to be following as researchers. So let's start with our first little quandary, I guess, if you will, here. So informed consent, what's the problem in international settings? So over here on the left, requirements for informed consent, they've got to be informed, so that you have to be accurate and true, et cetera. You got to tell them the truth about what you're doing, obviously. Consent must be given freely, and the use of written documentation. Is that required? Signatures, otherwise, things of that nature. You got to figure that out as well. So what do you think the problem is in international settings? What sort of challenges do you think we face? Language. Language is a big one. Probably our number one problem. Why do you think language is our number one problem? There's plenty of people that speak multiple languages.
Translation.
Translations don't always translate, right? So who's our second language speakers in here? What do you speak?
French is missing.
French ain't gonna work. Sorry, that's a regular language. Who speaks something a little bit more obscure? Creole? Is that what you got, Alyssa? Okay. How do you say randomization?
I wouldn't even know how to say I was fluent.
Venipuncture?
Yep.
No takers? Any other languages in here? Swahili? Randomization? Got a word for me?
It's just a shrug.
Venipuncture? A word for that?
Nothing.
So it'd probably take 4 or 5 paragraphs or sentences or so to probably explain, what you're actually trying to do, right? So language becomes one of our biggest challenges. It's not as simple as just translating a document and having somebody read it. Somebody also said culture. Who would say culture? Well, what about culture do you think is challenging with the informed consent process?
If you're in a male-dominated society and you're studying women, the woman, is she even allowed to talk to you, let alone give consent over anything?
Okay, good. That's the example we're going to talk about in just a second here. Yeah, good. All right. So you definitely have patriarchal situations where you've got to figure out whose consent do you give, or do you get it from, rather? Who's supposed to be giving the consent? Sometimes that's multiple layers to that as well. But one of the biggest challenges that I think we've come across is the fact that we're coming from this Western construct that has individual at the center as the autonomy, the decision maker. It's you as the individual. But in a good chunk of the world, as many of you probably know who travel or live in other parts of the world, it's often a communal decision when it comes to informed consent. That begs the question, who do you get consent from? And is that going to meet the requirements set forth with our common rules in the United States, as well as the cultural nuances and legalities of whatever country you're working in? So the autonomy of the individual in decision-making versus the role of the community in decision-making. So oftentimes, again, when we're overdoing a study, first stop we need to make, I'm going to go a little step higher here, first stop you make is the Ministry of Health, right? I mean, that's step number one. Get permission at the country level to even be there. Step number 2, let's say you're doing some sort of cluster randomized control trial or something like that, is going to be some sort of village mayor, elder, chief, somebody who's in charge of that community. That's step number 2 for informed consent. That often requires a different document or perhaps just a discussion. So that begs the question, is written documentation of consent required? Do people have to sign off on consent forms?
For us, yeah.
For us, we do? Really?
The U.S. Well, I guess it depends on the type of study.
Okay, it depends. That's a much better answer. It depends, right? It depends. Same thing overseas. It does depend on what you're up to, the type of study you're doing. What do you think the problem is with having signatures required for obtaining informed consent in a low-income country?
They don't know how to write.
Okay, literacy. That would be challenge number 1. Anybody else? Literacy is big, but that's not the only issue. Yeah, what do you think?
Could the consent be persuaded by money if there's monetary value in them agreeing to the trial?
Yeah, so what's that called that you're describing?
Bribery?
Not quite bribery, but it's coercion, right? That's called coercion. And yeah, you do have to state or describe how much one will obtain or earn if they participate in the study. But with the signature, another challenge that we found, and this actually applies mostly to West African countries that we've worked in, you only sign a piece of paper transfer of property involved. So getting somebody to sign a consent form, that's not going to happen, right? So there's that. They're only going to, they're obviously all of a sudden you're trying to take their farm or something like this. That's something we have to consider. So do we even need a document? Well, let's say the subject, somebody brought up literacy. Let's say they can't read. Do we need a document? Would it be ethical to put a piece of paper in front of somebody that cannot read and ask them to sign it?
Could you get like a video testimony?
Yeah.
Okay, maybe. You got a video camera on you? I guess you have to plan ahead.
Phone, can I record you saying you understand? I don't know. Does that work?
That could work. Could work, yeah. Any other ways to get around that?
You just document yourself and then get a witness.
Okay, we can get a witness. Yeah, witness is often the way we'll do this as well. Yeah.
You can get someone represented.
Now that's tricky. That's a tricky one. That's going to be a function of their age, mental capacity, how sick are they, if it's some sort of drug trial, something like that. But yes, that could happen. You would need a legal representative if they are incapacitated or otherwise unable to clearly understand what's being said and done. Any other ways to do this? Thumbprints, okay. We've done thumbprints as well. Think that would work in the United States?
Maybe. Depends.
Gonna go with the pens again? What do you think? Think a thumbprint's gonna work? You gonna give up your thumbprint?
Maybe. It'll be hard to have to compare a lot of thumbprints.
Yeah, I don't know what a thumbprint's gonna get us here necessarily, or even overseas. I'm not sure what it contributes. But
It's not authorized. It's just a thumbprint. It's not saying I agree to anything. You could have cut my thumbprint off a glass of water.
it's a unique identifier.
But it doesn't mean I agree to anything.
What about if it's on the line that says you do agree? Yeah, see, there's no answers in this session, only questions. Yes, ma'am.
No, I was going to say, what about having the fairness about having someone have a copy of it? So if you are offering a piece of paper, say that we're going to have this discussion, the other person is going to need verification of it.
Mhm.
If there's no need, if they can't read, if they're not writing, you don't know who you're going to give it to. If they lose it, then there's no evidence that you've even done it in the first place. So
Yeah.
any kind of documentation probably wouldn't fly.
Yeah, it's tricky, and it's not required. It's not required. You can do oral consent. You can do verbal consent. Even in the United States, you have situations that allow you to do an oral consent process. The process is the same. The information is the same. You're still giving them descriptions of the study, how much they're going to be paid, how time is it going to take. All the elements of a consent document need to be there, but you can read this to them and get them to verbally consent. Now, typically, these are observational type studies that are likely no greater than minimal risk situations, that type of thing. But again, it comes down to sometimes we got to figure out who to even go to get these consent statements in place. So that gets us to sort of our obstacles here. We've sort of talked about this. Language is the big one. That's the first one. You've also got traditional languages versus official languages. And we all remember the imperialistic issues of the colonization of Africa. Well, a lot of the official languages in Africa are English and French, a couple Portuguese and one Spanish, right? But how many folks from those respective countries actually speak those official languages? That varies. And so which language do you put it in? You take the Democratic Republic of Congo, I mean, you're looking at 52, 56 languages, something like that, in just a couple provinces, perhaps. Official language is French. Not met too many people in DRC that speak French, right? So you got to figure out that. Lack of literacy, we mentioned that. Limited experience with Western medicine, and even how to translate that as well. You know, venipuncture, finger sticks, randomization, things of that nature. The multiple IRB issue we talked about. Potential misunderstanding of documents. You know, am I signing my form away? Or is this really just you wanting to take a drop of blood from me and ask some questions? And then do you have to actually get written consent if it is associated with some other activity in a particular area? It's not an easy process, you know, by any means. Very difficult to do this, for sure. Oftentimes when we are setting up studies, we'll need to, you guys are all familiar with sample size and power calculations, things of this nature. Okay. We often need to add around 50% to our sample size just to account for the non-response that comes along with these issues. Whereas in the United States, a typical non-response inflator might be 5% or maybe 10% at the most. But we're often adding 50% to account for the fact that we've got a lot of obstacles to overcome, and oftentimes we don't even achieve what we need for our sample size. So definitely that's a challenge. So here's sort of our scenario number one for you. And this lady up front had already alluded to this already, but we'll chat about it briefly real quick. So you're conducting a study in rural Pakistan related to adolescent reproductive health. We're going to do household surveys, and individuals in the house are going to be interviewed. We're only concerned about women 15 to 19 years old. And this is predominantly patriarchal with strong traditional values and customs. This is a study we actually did a few years back, about 10 years or so ago. Who do you obtain informed consent from? Say that again?
Father and daughter.
Father?
What's the male
Okay.
patriarch?
Yeah, I guess the leader of the household.
The husband, yeah.
But yeah, 15 to 19, unless they're married, they're probably still at home.
15 to 19, they're probably married.
All right, so we've got father, husband. Any others?
Older brother.
Older brothers.
Whoever the male.
Yeah, older brothers.
is.
The patriarch, I guess, of the family.
All right, so do we have anybody from Pakistan in here? Or India? India. What's the age of majority in Pakistan? Do you know?
No idea.
I think it's 17. That's what I think, the age of majority.
In India, it's 18.
It's 18? Well, maybe it is 18 in Pakistan now, too, then. Okay, so we're talking about 15 to 19-year-olds. Do we need consent from the young lady who's 15?
Yes.
Assent.
Well,
According to.
You're going to go with
Yeah.
assent?
yeah.
Anybody else agree or disagree? Who says assent? Few tentative hands show up. You don't want to get called on, right? Sudden movements. Remember that. Sudden movements will get you called on. Who's going with consent? All of a sudden, nobody's going with consent here, right?
According to which set of rules?
Yeah.
Well, which set do we want to use? This is another one of our challenges.
We would have to do.
We're sitting in rural Pakistan. Whose rules do you think we're following?
First,
Pakistan. Absolutely.
So first, you have to get the patriarch's approval. I would think as a U.S. researcher, also want the girl's approval.
Yeah, but she's underage.
Underage. So is it assent or consent? And she's also married. Let's just make it more complicated.
Can we just contact the Ministry of Health and follow whatever their protocols are?
Yeah, we did that. But there is no protocol. Yeah. But that is a very useful fallback position. Is follow the institutional review guidelines from the host country. And in fact, I mean, we've made a pretty strong push over the last 5-6 years to defer the oversight of these international studies to the local institutions' IRB. Because again, this is not our country. I mean, we can't act as if this is. So it's best if we can follow their rules and ours And we still got to deal with our IRB too, but we let them provide the oversight, and that sort of eases up a little bit of our liability, if you will. Yeah.
Shouldn't WHO rules just apply everywhere?
Well, what's the WHO rule?
Well, I don't know if there is one, but I guess the way I believe these kind of things happen is there should be a WHO representative of that country who understands whatever their rules or whatever is followed.
Yeah.
They just change it according to wherever they are from, and they work together.
Okay, that's a very good point. Now, it's not WHO necessarily.
Whoever, yeah.
Yeah. But we do need to get someone outside the context of the study to look at what we're doing from an ethical and cultural standpoint and approve it, right? That has to happen in the form of a written letter. Someone who can read, write, sign, et cetera, that says, I've looked at the consent document, I've looked at the study documents, the protocol, and what you're doing is ethically correct in this country. So there really is no right answer. So it depends is the right answer. We'll go with that right here. So how do you ensure the privacy of the respondent? Because again, remember, that's one of those regulatory requirements for approval in the United States is maintaining privacy and confidentiality of human subjects. How do you maintain the privacy of the respondent? What's that?
They're not allowed to be with you in the same room alone.
Who, like with me?
Well, specifically you. You're a male Western.
Well, I am, but believe me, I was nowhere near the data collection when this study took place.
Well, I guess you would have to have a representative from that culture, from that.
Yeah, and in fact, we do. I mean, it's never us collecting the data, right? That's another big difference as well, right? A lot of times here it's physicians, nurses, et cetera, program managers that are collecting the data, the consent, things of that nature. When we're doing these population-based studies, I mean, in this particular study, we probably had 6,000 data collectors or so, going on. So, I mean, we needed to get to like 25,000 people. So, it's not the research team that's doing it.
Don't use real names.
Okay, right? Yeah, keep any identifiable information off the record, off your records. Yeah, absolutely. That's a great way to do it. What if the husband insists on sitting in on the interview? How do you handle that? It's reproductive health, right? So we're talking about sexual activity. Not going to use it?
We have to.
I could jeopardize the study.
Yeah, what do you think?
You could ask him to ask her, so that way he can filter the questions in the way that he understands and have a translator to make sure that the questions are happening.
All right, so let's try this. Let's do a little experiment. All right.
I don't want to do this. I don't want to have
All right, so I'm your husband, and our data collector's here, and he's asking me or asking you, how many sexual partners have you had? What's the answer?
Well, I'm sure that he's probably
The
going to
answer's one.
Yeah, he's going to.
Whether
So
you tell
what
them
do
the
you do
truth
about
or
it?
zero. Yeah.
Or zero, depending on where you're at in the relationship. But it's either one or zero at this point, right? So having a husband in the room is obviously not a viable way to ensure privacy by any means. But it's also not proper to say if the husband wants to sit in there and listen to this interview, you can't just abruptly end it either. Why not?
Because that's going to clue them in on whatever you're asking.
This could turn into trouble for the young lady as well, right? So you've got to be very careful. Often what we'll do is start skipping around at that point. We're not going to use these data. We just start skipping around. What's your education? What's your occupation? Where are you from? Things of that nature. See you. Thank you for your time. Here's your payment, and off we go. And we don't use the data. That's often what we do. So. And then what do you do here if a subject accepts to participate but will not sign the consent form? What do we do about that? Let's assume we need one. Yep, it's out, right? It's out. You don't sign it or don't follow the rules of whatever protocol says you're doing in that context, that particular situation. So anyway, informed consent. This is probably one of our trickiest issues to get around when we're doing international research for sure. So here's another one for you. I know what we're looking at here. I know a couple of you do, but all right, I'll fill you in the interest of time. So as Lisa suggested, I do mostly malaria research, and oftentimes we have to figure out what's the transmission intensity in an area. So how many infectious bites are you receiving per person per unit time? And so the best way to do this is to get a couple people willing to do this and have one person be the bait, that's the guy on the right. The other guy on the left sits with a tube and an aspirator, and every time an Anopheles mosquito lands on the individual leg, he or she will aspirate that infectious, likely mosquito, off the leg and put it into that cup you see at the bottom of the slide. And then we take them to our labs, dissect them, or smash them up and run them through PCR and figure out if they're infected, et cetera, right? So that's gold standard. So my question to you is, can we pay you to be in studies? And then we'll come back to this issue. But the issue is the title's compensation. Can we pay you to be in a study? Let's get that question answered first. Go with that all day long.
Well, I mean, I can yes and no's. I mean, you're asking the person to sit and possibly.
Forget this for a second. Let's just say in general, can we pay somebody to be in a study?
Yes, but not a lot.
What's a lot?
I was going to say, I think the idea is not so much to pay someone, but to compensate them for
Yeah.
any inconvenience. So
Okay, good.
It should be an incentive, just a.
Yeah, good. Right. So the idea is compensation, not payment per se, right, for their time. So when you say not a lot, that's a relative construct, of course. Their time, parking, lunch, perhaps work missed, things of this nature, and that's going to vary from place to place, right? $100 might be appropriate in New Orleans. $100 in Nairobi, Kenya might not be appropriate, right? It just depends on where you're at. So let's get back to this right here. In this particular study, this took place in Kisumu, which is in Western Kenya. What do you think the compensation should be?
Beer.
What's that?
A beer.
A beer? He's already got one in his
Well,
hand.
that's what you got him to stay there. You give him a beer.
Oh, yeah, you could bought it. There is no vaccine for malaria.
Treatment of.
Treatment?
Treatment of. If he comes positive with malaria, treatment.
That's it?
Prophylaxis.
You're going to go with prophylaxis instead? Now, they're from Kenya. All right, so let me back this up for a second. How much would I have to compensate you?
Sit out on my porch in New Orleans?
No.
And get mosquito bites.
And get
Out
mosquito
here
bites.
in Kisumu. How much do I got to compensate
But that's
you?
different.
You got a number for me? You got to do it for 12 hours.
Okay.
12 hours.
12 hours. I run a high risk of getting malaria. I have about 100,000 student loans to pay off. How about that?
100,000?
Yeah.
I'll give you 100,000. We'll do it for 100,000. You're in for 100,000?
Pay my trip to Kenya.
That's even less.
Well, no, that's in addition.
Oh, in addition, yeah, I'll pay the trip too. Yeah. So that's coercion, right? So that's not allowed.
We were in India earlier this summer, and it was a routine of 30 pills that we had to take starting 7 days before we got there. And
Yeah, it depends on what drug you're on, Malarone or something.
Something like that,
Methylquinone,
but
yeah.
something that would help against malaria.
So the problem you run into, especially when you're an indigenous population in an endemic country, is that you can't give prophylaxis. You can't give prophylaxis. That's not standard of care by any means. Now, for those of us that have not regularly been exposed to malaria parasites, we can do prophylaxis and it's going to help us, right? But that's also going to do more harm than good in a situation where someone's always being exposed to parasites. These parasites that are already in their body will be exposed to sublethal doses of the drug, which could potentially lead to drug resistance, and then we've got a huge problem on our hands, right? But the point of this is we can compensate, we can't coerce, right? We can compensate, but we cannot coerce. So how much is the right amount? I don't know. I mean, I don't quite remember what we paid these fellows in terms of compensation, but we did treat them at the end. Not prophylactically, but at the end, we did give them a lethal dose of Fansidar at the time. This is 1999 or so when we did this study. And so that was part of the package. We will clear all parasites from your body at the end of the study. Plus, we'll pay you for your 12 hours of sitting out here drinking beers. And being bitten by mosquitoes is not fun either, necessarily. For anyone who grew up or did their doctoral studies in the 90s who worked in a mosquito lab, anybody fall into that category? You guys ever, nobody here had to feed mosquitoes in the lab?
No.
You put your arm on top of the cage and, to see how long you could hold it there with thousands of mosquitoes. Yeah, it's a bloody mess. So a lady from Brazil who I went to school with held the record for years on that. All right, so that's compensation. That's a little bit more straightforward in that with this, we can actually just ask authorities in a particular country context and get a good number of what's fair, right? And then have that not be too much and feel comfortable with that. So that's not too big of an issue there. So, okay, so here's another scenario here. This gets at compensation because we're all familiar with this scenario, I'm sure, right here. Henrietta Lacks, or Gila, the tobacco farmer who sells, taken without her knowledge, without consent, back in the 50s, became one of the most important tools in medicine, vital for developing all sorts of vaccines, gene mapping, cloning, etc. Never gave consent for her tissue samples to be used in research, and her family didn't either. To date, nobody's been compensated. So the question, who controls the tissues and the substances that make up humans in general? So let's start with question one, first part. Who controls these tissues, or who should control
The person.
it? She's dead.
Well,
She wasn't when they took it.
yeah.
So what should we do with the tissue stuff? And then all the byproducts that have come from it. Because technically, right, you go do a study without getting a subject consent, and anything you collect is out the door. It's done. It's no good. You cannot use this unless you go back and get consent. That goes for survey instruments, blood samples, tissue samples. You want to use it, you got to get consent. So we didn't get consent, and we've gone on to do all sorts of things with it. So what should we do? There's actually no answer. I mean, we're still trying to work through this. I'm sure there's teams of lawyers that are on this right now. But what do you think? What should we do about
Do
this?
something for the family at least. I mean, especially if her family can't afford health insurance. I mean, the least.
Who should pay?
The company who originally took the sample.
It's out of business.
The government then, because they didn't oversee it.
Which government?
Our government.
But plenty of governments have taken advantage of this technology, these samples, these
But it's the
tissues.
responsibility of our government for where it wasn't overseeing the collection of.
We didn't have the common rule in place in 1951. When did the common rule come in, Brian?
I think it was 1992.
92. All right. 41 years later. So no common rule in place. So theoretically, no federal regs in place in any serious fashion that would require this. So who pays? And then who should be compensated? How far down that line, that lineage, do we need to go?
All of it.
We're talking 60, 70 years here of people.
How many people are you really?
Well, I don't know. I mean,
Compared to the people that the polio vaccine saved, I mean, 60-some people, it's not that bad.
well, I didn't say 60 some people. I said 60, 70 years of people.
Well, then that still doesn't compare to the polio
So
vaccine.
how much should they get?
I don't know, maybe a percentage of whoever's making the polio vaccine now?
Well, that's Gavi. That's the Global Alliance Vaccine Initiative.
Maybe they get a percentage of their profit.
The United States subsidizes that country. So do other countries. They provide the polio vaccination for free. Yeah.
Are there other cell lines where people actually have profited? I feel like pretty much all cell lines are taken for free.
They are, but
Yeah.
but there's also consent given these days. You want to allow your cell line or your tissue to be used in research, genetic or otherwise, you check a separate box on that consent form that allows that to happen. The issue here is no consent.
But wasn't with the case of the HeLa cells, weren't they sent out, like scientists were sending out to each other? They were sent out to different countries around the world.
Yep.
It's not just here.
That's right.
And so that's literally a global, like the world, the scientific world has changed. HeLa cell. So there's, who can we charge? Like you can't start billing other countries like retroactively. Right? So I don't think that there's an answer to that. I mean, I think that I definitely think the family should be compensated. But it's so far spread because, all the social stuff was going on during the 50s where we were considered human and they had to go through a separate entrance to even see a doctor. Like the whole situation is just so convoluted that I don't think there's a direct answer in terms of like how far back or who to trace to get compensation from.
Yeah, no, I agree. I think, well, I don't know at all where they're at with the legal aspects of this, but it is ongoing.
Do you know what the family wants?
To be compensated.
Have they voiced any preference?
Yeah, there's a book.
Yeah, there's a book. Yeah, there's a book. I've not read it.
Scholarships and insurance.
Probably so. Yeah, what do you
They
think?
only map the genome of the HeLa cell, and since that implicates her family, living family members, and could point out things that might be genetically wrong with or anything. But anyway, they currently sit on like a panel with the NIH that is helping to oversee the use of that data. So they're active in kind of making decisions as they're relevant to HeLa today.
That's good. Yeah, how long have they been doing that for?
I think it was probably 2018.
Oh, that's recent.
Wow.
Yeah.
So the genome was actually mapped, so they formed that committee.
Yeah. Interesting. Well, anyway, no solutions on this slide either. Once again. So moving right along, risks and benefits. Here's your polio vaccine right here that we were just speaking of. This is the oral polio vaccine. This is taken in Ouagadougou out in Burkina Faso. So how do we establish what risk versus benefit? How do we do that in the United States? We can start with that. Risk versus benefit. Because that's part of the rules, right? The benefits of your study need to outweigh the risks of the study. That's part of it. How do we do that here?
Go to the IRB board and ask.
I'm just going to say, I don't know. I mean, I'm not an expert on your topic, your expertise, right? I do malaria. So if you come to me with metastatic castrate-resistant prostate cancer, I've got no answers for you at all. Or some crazy drug you've just invented. How do we do it here? You guys are overthinking this one. How many here do research? Hands are not going very well. So how do you do it? Did your hand go up, or was that just?
Yeah, of course.
Yeah, how do you do it?
I mean, I work with mice, so
it's still a similar process.
I mean, there's a panel that oversights, what we can and can't do with the mice. Humans, I mean, explaining the risks and benefits be done with someone that can do it. Someone that can communicate. You have to actually understand it. You can't like nod your head. You have to be able to verify that someone understands the risk and benefits. So,
anybody else? Yeah, we got a human example. The mouse thing.
So I come from the financial world. In the financial world, you put dollar values on you just assign dollar values to like everything. Your time in the lab, the possibility of everything gets a dollar sign, and then you do a cost benefit.
We can't quite do that here. How so?
You talking specifically about the malaria? This particular study?
Oh, well, we're on to polio here, but this is a different discussion in a second.
Okay. So
First.
all the actual hard costs, and then you do your best guess estimate on the soft costs, and you probably triple those. and then you try and determine whether or not your product is going to be of significant benefit to offset those costs. I feel like I'm talking in circles.
All right, so let me put a little twist to this for a second here. All right, so this picture was taken back in the middle 1990s or so, and this was a brand new polio vaccine. Right, this is back when OPV was actually beginning, the oral polio vaccine. This was taken during a safety and tolerability study. So we didn't even know if it would kill you or paralyze you.
Okay.
Does your financial analysis still work here?
It just goes up.
Sort of.
Because keeping in mind that polio in and of itself can paralyze up to 5% or so that actually get it in and of itself. And now we're using a live version of this in an experimental setting. Yeah, what do you think? Okay, good. Yeah, that's a very big first step. So right here, we've already done phase 1, phase 2. This has already happened. This is moving into phase 3 with a safety and tolerability study sort of attached to it as well. So the answer here is we don't know whether or not the risks are going to outweigh the benefits for the individual. But fortunately, we've got 2 sets of risk-benefit analyses that we need to perform, indirect benefits and direct benefits. So you can actually conduct a study that has 0 direct benefit for the individual, but has the potential for indirect benefit for the society as a whole. And that's what this is getting at right here. So the potential for indirect benefit for the society. I don't mean to sound crass when I say that, but even if we saw a mortality rate associated with this new type of vaccine that's being rolled out, and maybe that's when you do some sort of, looking at the data to see what we're looking at here in terms of real risk. Was that an adverse event that just occurred? Was it unexpected, expected, things of that nature? We're trying to figure out what happened. It still might continue to roll out depending on, again, what actually caused that adverse event to occur. Right? So direct benefits to the person and indirect benefits to society can cancel each other out. Maybe that's not the best way to put that. No direct benefits to the individual can be canceled out by significant indirect benefits to society. And vaccines are a classic example of that for sure. A lot of people have died along the way of development of vaccines, across the board. All right? So tricky for sure. This gets back at that cultural nuances again of international settings, trying to explain this to somebody. And anybody familiar with African sleeping sickness or trypanosomiasis? Right. Okay. Yeah, a couple of you are. So now they've made some strides with the medicine these days, the cure. But try this out. Try knocking on somebody's door, telling them that they've just tested positive for trypanosomiasis, which is similar to Chagas disease that we see in South America, but manifestation is different in Southern Africa. You're going to be dead in about 3 months unless you take the treatment right now. But you've got about a 15 to 20% chance the treatment's going to kill you because it contains arsenic. Try that one out, explaining that. And this person is seeing no signs or symptoms at the moment. It takes a little while for that to kick in, for circadian rhythms to change and things of that nature. Yeah, I've never had to explain that to anybody. But anyway, just thought you'd mull that over. Another challenge for sure. Okay. So then we also got to figure out sort of scientific and social value. What should we be doing? All right, so what you're looking at here are spraymen. Study we did in Eritrea in 2010, I think, maybe 2011. And everybody familiar with that or heard of that? This is a way of so you think about vaccines and herd immunity, same concept with mosquitoes, where if you can spray enough houses indoors, 75, 80% of the community, for example, you can actually stop onward transmission of the malaria parasite by killing mosquitoes that are resting on walls. So it's not going to offer you any personal protection because after she bites you, transmit the parasite, now she's going to the wall to rest, and this is going to kill you. Kill her. Sorry, kill her. By her, I mean the mosquito, right? And so only female mosquitoes bite. That's why I'm saying. But the question that the government hired us to answer was, what's the added value of using DDT in the form of indoor residual spray over and above what we currently use, pesticide-treated nets, prompt and effective access to treatment, and larval control. And so we set up a cluster randomized control trial to go test that out, answer that question. What do you think? Do you think the scientific value outweighs the social risk, environmental risk of what we're doing? DDT. We're spraying walls inside your house, taking everything out of your house, spraying all the walls, putting everything back, and then giving you specific instructions to don't touch the walls for a little while. You can touch them after a month or two. Although DDT's residual efficacy lasts about 1 year or so. Half-life's like 10,000.
It was deemed acceptable because you did it.
What is Eritrea? Eritrea is tricky.
I don't think it would work here.
In terms of human rights issues, they're like right next to North Korea. So this was not a hard environment to conduct the study. And we had about 98% compliance.
Wow.
It's a pretty autocratic situation in this part of the world.
And so
Yeah,
were
Alyssa?
the negative effects because you used DDT specifically, or could you have used a different incentive? Just for context, because I didn't think IRS was necessarily seen as like a negative thing.
It's not seen as a negative thing when we're using plant derivatives like permethrin or
Yeah, that's
pyrethroids
what
and
I'm
deltamethrin, things of that nature. But this was a cost decision. You think about what's the financial cost to go out to every single house in an area and spray. The residual efficacy of DDT is 1 year, deltamethrin maybe 6 months, permethrin maybe 3 months. This is a cost issue, plus it's going to give you your biggest bang for the buck. If this doesn't work, then the permethrins and deltamethrins probably aren't going to work either, right? What do you think? Think this is acceptable to do?
Here?
In general?
In general? I mean, I'm glad I'm not deciding.
It depends what's your net usage. If the benefits, if you're going to be able to reduce morbidity and mortality from malaria by doing that at a higher rate than
So they were going for elimination, right? So they dropped parasite prevalence from like 60, 70% down to 1%. And they were trying to get that last 1%.
I don't think it.
I guess I would look at the risk of like women and children around those, the variables.
The
like,
home.
It's all good as long as your kids don't lick the walls.
Which, yeah, good luck.
Yeah. The wall and like.
Yeah, I mean, how do you think we eliminated?
DDT.
We sprayed the crap out of DDT.
Oh, DDT. Yeah. But
That's
that
why
was
it got
before
banned.
That's before we knew what it.
Well, we kind of knew.
Did you have any stats on how many people were liable to get sick as a result of something?
Well, historically we know.
Not from the malaria, I mean from the DDT.
No, historically we know what this stuff
That
does.
does.
Yeah, historically. It's been banned since 1971.
I think it makes a difference because it's, I don't know, just inherently it's your benefit. I mean, what's your case count at that point? You said your parasitinias was a certain percent.
Yeah, down to 1% or so, 0.5%. I mean, it was low.
I guess
come
it's
back
like
up. So I feel like
Say it again?
it could come back up. So I feel like it could be worth it to do it in that scenario to finally really get rid of it.
But are you really getting it? How can you say that you're going to get rid of it 100% in this
And that's why we're
area?
doing
Well, that's
a
what we're
study.
testing.
Well,
We're testing whether or not we can.
but if you're not going to do it in the United States, then why put somebody else through it?
We did do it in the United States.
Well, yeah. And we banned it. So now why are we going to go and use it?
So to conclude on this particular discussion, we're up two things. Number one, Uganda's doing it, South Africa's doing it, parts of Mozambique is now doing it, DRC is going to start doing it. This study showed no incremental benefit of using DDT or any other IRS for reducing malaria transmission over and above what we're already using. But everybody's convinced that this is the way to do it. And so even WHO has gotten on board because, again, if you're only targeting arthropods of medical importance versus what we did in the United States, which was target arthropods of economic importance and medical importance, But if we're only targeting arthropods of medical importance, it's okay. I mean, look what the canister says.
Oh, it's aid.
Not in the U.S.
Not in the US, in this country, they
No, they're
were.
experimenting with, just like Eritrea did.
Really?
Yeah, Uganda, South Africa.
I thought it was like a telecourse.
South Africa's moved on to genetic studies now. They've been doing it the longest. And now they're looking at, offspring of people's houses were sprayed to make sure there's no malformities, things of this nature. So,
United Nations countries?
what's that?
Are there UN countries?
I don't know. But you see those 5 little letters at the bottom left of that canister?
Mhm.
Where do you think they got that stuff from?
Our stockpile we've been trying to get rid of.
Yeah, there you go. Okay, so I think we probably have time for one more scenario here. We got about 5 minutes, is that right? All right, so this is a good one. This also gets back to scientific and social value or benefits of the particular study. So we're in DRC looking at HIV infection. We're going to use health facility data to get our information. We're targeting women 15 to 49 years old. These are our reproductive age women. This is the area of the country distrusts outsiders, believes HIV largely related to prostitution and promiscuity, and so heavily stigmatized. So here's the question for you. Do you need to obtain consent from a patient to test them for HIV?
Yes.
Well, probably not there.
Everybody going with yes? You're shaking your head no?
It just seems like you wouldn't ask the question if the answer.
What do you think?
Here, yes. There, probably not. I guess it depends on their laws. But
Forget the laws for a second because this is a little bit trickier. I don't know what their laws actually say. DRC better not to ask. But in this particular situation, number one, do you need consent to test for HIV?
probably not.
I got about half saying yes and half saying no. So just in the interest of time, the answer is no. If you're using residual blood from some other purpose. So this is called unlinked anonymous testing, right? So we're looking at parasite or looking at HIV prevalence here. There's no other way to get a prevalence statistic. You can get an incidence statistic, of course, by following cohorts, things of this nature, but no other way to get a prevalence statistic. So they're actually using, in this study, we used, it wasn't me, they used the residual blood from syphilis rapid diagnostic tests. And so de-identified, basically they test the kit and it's positive or negative, which then begs the question, do you got to provide the patient with the test results?
You can't tell.
You request to be tested.
You don't know. You don't know who it is.
Yeah.
You don't know who it is.
And that's
if it's an anonymous.
Yeah. Yeah. Well, what if it's positive though, and you do know who it is?
How would you know?
Well, let's say it's before you unlinked it. They only unlink it when it hits the data set, not the cassette necessarily.
I would think you would. If you know the person, if you honestly know who it is and can track them down, morally, I think you have the right to.
Only if they can
Tell
be
them.
treated.
What if they don't?
Or if they would get stoned.
Yeah. What if they're going to get ostracized from the community?
Well, but you can tell them anonymously and then let them decide who of their family or community.
It seems like if we didn't obtain consent from them first, that we don't
Shouldn't say
necessarily.
to tell them.
Maybe that's not a good idea. Yeah.
Yeah. Anybody else?
You don't want to out anyone who is gay and doesn't want anyone to know or any of that.
No, especially not in DRC.
No.
Yeah. Well, in the interest of time, WHO policy does allow for unlinked testing. It does not require that you tell them the results of their test, positive or negative, either way. And so, anyway, I think there was one more slide or one more scenario, but we're out of time. It's probably in your packet or something like that. Or something. Thank you for your time.
3 logistics things.